All right, cool. So as you guys know, after SIM we kind of debrief and we go over the facts of the case. So I'm going to do this really quickly. 50-year-old guy, LVAD, transplant. He's got rails. When he's coming to chest pain, he's got rails on the right lung. The LVAD appears to be working. He's hypotensive. He's got symmetrical edema. He's not febrile, and there's no evidence of LVAD infection. He's not too altered. We didn't get a great neurological exam in the case. The EKG, there's no STEMI. There's maybe an S1Q3 T3. The chest X-ray shows a right lung thing. Maybe it's an infiltrate. Maybe it's an infarct. The echo shows a large RV, and the patient goes into wide complex tachycardia at some point. In terms of our team's management, we get some fluid. We did try to contact the coordinator. We defibrillated the patient. We gave antibiotics. We intubated. We put in an A-line. We gave TPA. We did chest compression. We did CPR, and we got consults on board. And then, unfortunately, the patient did not survive. Okay, so things that we want to think about in these patients. These are the problems that they can have. Their LVAD can stop working for some reason. So that's one problem. They have bad hearts to begin with, and they can have worsening hearts, and that's what brings them in. So they could have a new MI. They could have arrhythmias, and they could have worsening right ventricular failure. Now the arrhythmias they have bad hearts to begin with. They're big swollen hearts, but they also have had surgery. They have foreign objects in their heart now, and there's going to be scar tissue and remodeling. So arrhythmia is a huge problem. They also are anticoagulated. They're probably going to be on Coumadin. And they also have an acquired von Willebrand's deficiency because of the LVAD. I'll let some other person talk about why that is. But they can bleed. And they also are thrombophilic. So they can have PEs, LVAD thrombus, thrombi, things like that. And lastly, they've got hardware in their body that's coming out of their body, and so they're prone to sepsis. And they're probably immunocompromised to begin with. Okay. In terms of our ED toolkit, these are the things that we can potentially do. We've got fluids, blood, antibiotics, respiratory support, BiPAP, oxygen, intubation. We can get pressors if they're hypotensive. We can get inotropes if we want more squeeze. We can heparinize. We can give TPA. We have our antiarrhythmic medications, amiodarone, whatever else. We can correct their electrolytes. We can do adjustments to their pre and after load. And we obviously have our consults for more specialized care. Now, for the 3rd and 4th year residents who are there for Dr. Ritchie's lecture this morning, just anything I say about right heart failure, just ignore it and refer to what he said, because I was wrong. I think I say some things that are not correct. Okay, so okay, just to review the critical actions, and we'll talk about this. But ABCD, IVO2 monitor. We need to, as Dr. Kim did in the video, you got to get an actual blood pressure because they don't have a pulse normally because they have continuous flow in their pump and their LV doesn't work. So you have to get their blood pressure, specifically. You got to check the LVAD machine. You got to get EKG, bedside echo, and then know what you can fix and what you can't fix. So starting with the LVAD itself. So I personally have not seen this. I think maybe I saw last time some people had seen LVAD. Anybody here seen an LVAD patient so far? All right, yeah, a bunch of people. Okay. So one thing you got to do is check to make sure that pump is actually on, and you just check the machine and see if there's a green light. If the green light is on, then it's working. If the green light is off, it's not working. You gotta unplug stuff. You gotta plug it back in, hook it up to the wall, do anything you can to get that green light to turn on. And I know, right? Green light on. I'm a simple person. And that's actually, this is where contacting the LVAD coordinator, if you can get them on the phone, have the phone in your hand as you talk to them, may really, really help you. They may be able to walk you through the machine and troubleshoot. Sorry, the next thing I'm looking to mention is that you can also listen to the heart. They did this in the video. If you hear a whirring motorized sound, the machine is probably working. If it's absent, if you don't hear any heart sounds or anything, it's probably not working. Okay, the next branching point is the machine hot? Does it look like it's getting overloaded? There's too much power going through that machine. There are work parameters, and I'll show you a picture, that you can refer to. The flow rate, the RPMs, the power, something called the pulsatility index, which is inversely related to the native squeeze of the left ventricle. So these are various parameters that exist that you may be able to access on the console. This is what one of them looks like. Sorry if you can't really see, but it shows RPMs, flow rate, and the power, or the watts. There is a guide that exists. It's made by EMS. This is from 2014, which I think is the most updated, and it has guidelines for all the on-the-market products in the United States. And it shows you how to troubleshoot them and how to figure out those parameters that we talked about, if you might be able to make adjustments to correct whatever problem is happening in the machine. Probably better to do this on the phone with the LVAD coordinator, but if you can't get in touch with them, there is a resource that exists that's condensed in one place. Okay, so just to go back to the hot machine. If you think the machine is, the patient comes in sick, hypotensive, the machine is hot, and if the control unit is showing decreased flow, increased power, then you might think this is actually a clot thrombus. That may be the most likely diagnosis in this case. And then, and this is the initial branching point, and the treatment then would be to heparinize the patient. Heparin. Now, if the patient is dying and they're losing their vital signs, then you can treat it like a massive pulmonary embolism or other kind of heart failure, and you can give your TPA equivalent. Next, if the LVAD is working, the LVAD, the green light is on, the work parameters, the flow parameters are kind of normal, the machine doesn't seem hot, you hear a normal whirring sound and heart auscultation, then the problem is outside, and probably it's outside of the machine, it's with the patient. The patient's own body is malfunctioning somehow. And the next step would be then to get an EKG. If they're having a STEMI, you're going to treat it like a STEMI. You're going to call the activate the cath lab, get cardiology, and they'll make the determination, is the patient, yeah.
Does LVAD change EKG in any way?
I don't know. It definitely will change the rhythms of the heart and give you abnormal rhythms, but I don't know if it'll distort the electricity, the reading of the EKG. I'm not sure. What's that?
There's a hole in the ventricle.
Right, the hole in the ventricle, I'm sure it does. I'm sure EKG, but I don't think STEMI, I don't think it would like create a false STEMI. Maybe it would. I'm not sure. Sorry, don't know the answer. The EKG and also the monitor may also, this is the next thing, is to look for arrhythmias. As we talked about, they have hardware in their heart, they have scar tissue, they have bad hearts to begin with lots of remodeling. The patients are very susceptible to arrhythmias. They also may be on multiple diuretic medications, heart medications, causing electrolyte abnormalities. They may have coexisting renal disease, end-stage renal disease. So we should definitely check their electrolytes and think about electrolyte abnormalities and try to correct them where possible. The other thing that can happen is something called a suction event, and we'll get into the physiology a little bit more, but if the patient goes into a low volume state for whatever reason, if they're bleeding or septic, and there's not enough preload in the left ventricle, then the machine detects that by increasing the revolutions per minute in the pump. It's going to try to get more fluid going through the pump. But if there's no fluid in the ventricle, then the myocardium itself can actually fold into the pump, and that's called a suction event. Yeah, bad. It's bad. The machines, however, are actually designed to anticipate this. And if that happens, they'll ease up on the power and try to let the myocardium fold back into place. But that doesn't fix the problem of low volume, so the patient's still very sick. But when that happens, they may go into a wide or some arrhythmia. When the suction event happens, they may have an arrhythmia. And that could be what happened in our particular patient. If he did have a PE and wasn't able to get fluid into his left ventricle, that may be why he went into that arrhythmia. And the treatment here is not really different from our normal treatments. We can shock arrhythmias. You can shock an LVAD. We do our ACLS. We can try to give antiarrhythmics. We can correct our electrolytes. The next thing I want to talk about is what Dr. Kim did in the video, and that was obtaining the blood pressure. So we get blood pressure through pulsatile flow. When you feel somebody's pulse, you're feeling the pulse, the squeeze of the ventricle. These patients don't really have a ventricle that works, so you can't feel their pulse. You also can't get pulse oximetry for the same reasons. So what you can do is get your thing that I can't pronounce, sphygmomanometer, and you can get an ultrasound, or you can try to listen if you have really good auscultation. But you can try to identify by the anatomy of the radial artery and put some Doppler on it, squeeze out the cuff to occlude the brachial artery, and then slowly let out the air. And when you see, through Doppler, when you see some reading of blood flow, that's your MAP. That's more or less, that's your mean arterial pressure. You may see small upticks in your Doppler reading, and that is most likely the native ventricular squeeze that's still adding a little kick. So that's how you get blood pressure. Our team did this, and this is probably a good idea in a sick patient, is to put in an arterial line so that you have constant monitoring of blood pressure, so you don't have to get an ultrasound and try to find the radial artery every time you want to measure blood pressure. Just put in an arterial line. And then in terms of the pressure targets, they're the same as in any other patient. Okay, so now I want to talk about the role of bedside echo. How am I doing on time?
You're okay, another 10.
Okay, cool. So bedside echo is the next critical action for this patient, for this sick patient. There's basically three scenarios that I want to look at. The first is what we see here, and I apologize for these echo images, they're not like 100%, but what I want you to get out of this is a big RV, and that's what we saw in our patient. So most likely this is right heart failure. And the etiologies for this, as some of the our senior residents saw this morning, we have our worsening pulmonary hypertension, a big PE, a new MI on the right side, hypoxic pulmonary vasoconstriction, so that in our patient in the SIM case had this big right-sided thing which may have taken this guy with a bad heart and pushed him over the edge in terms of his right heart function. And then just whatever, acute on chronic worsening right heart failure in a person with a very diseased right heart. And the treatments for this, and let me again now say after Dr. Ritchie's lecture, I would modify this a little bit, but you could consider giving IV fluids if they don't have a D sign and there's not evidence of increased pulmonary right-sided afterload. You can consider inotropes such as dobutamine or milrinone. And if you think they're having a heart attack and they have absolutely no wall motion on the right side, maybe they need to go to cath. And then if they're having hypoxia, acidemia, or other metabolic disturbances like that, respiratory support, high flow oxygen, BiPAP, and intubate if you have to. The next bedside echo scenario is bilateral ventricular dilation. In this case, it could be that the pump is failing, either the battery ran out, that got turned off. There could be a pump thrombosis, and that's a clot that's actually in the pump that stopped it. And then the other thing which is tricky is that these patients are susceptible to valvular disease because of their bad hearts, and they can have something called it's like a pump short circuit. Basically, if they develop new onset aortic regurgitation, and there's a couple of reasons why that could happen, but if it happens, the pump will be working. The pump's working fine. It's passing oxygenated blood into the aorta, but then because of the regurg, the blood's actually going right back into the ventricle. And so it's a short circuit and no blood is reaching systemic circulation. So this would obviously be a problem that we more or less can't fix in the emergency department. The other thing I wanted to mention about pump thrombosis, I forgot to mention, is that it doesn't just have to be a clot. Excuse me. There can be kinking of the cannulas and other things like that. There can be some dislodgement of the machinery, and that can also cause pump failure without a clot. But all of this would lead to left heart failure. For the treatment, if we think it's a clot, you should heparinize, as we talked about. You should give TPA if they're crashing. If it's an MI, give antiplatelets. And then if it's a machine malfunction, that's really where you need to get the LVAD coordinator on the line and try to troubleshoot together. Lastly, and again, all I want you to focus on in this picture is a very small LV. So that would be a sign of hypovolemia. They need preload. And the various causes of that, dehydration or distributive shock or bleeding, as we know they can do. They can have GI bleeds, retroperitoneal. And the treatments would be the same stuff that we are more comfortable dealing with. Give fluid, give blood, give pressors. You can correct their bleeding abnormalities. If they're really exsanguinating, the risk of them exsanguinating will outweigh the risk of correcting their INR. So you should do that if you need to. Okay, and lastly, I want to talk about CPR. So there's, I think our team did CPR, and I think it was completely the right thing in this case, the right thing to do. I think the arterial line is really, really important here. because if you can get an arterial line and you can get a constant map reading, then that will help you guide your decision whether you want to give CPR or not. Basically, the literature that I read said that we should avoid CPR if you can, but that's kind of like avoid like a moving truck that's coming in your direction. Like, yeah, you don't want to get hit by that. You don't want to have to do CPR in patients. So if you can get a map that is greater than 0, the patient has some perfusion, then maybe you should consider holding the CPR and trying to correct whatever problem you are able to correct. Maybe it's blood, maybe it's fluid, maybe it's pressors, maybe it's TPA, but try to avoid the CPR because you can, hold on, I'm almost done. I'm like 2 seconds away from finishing. And you can try more stuff. But if the map is 0, the patient's dead, the patient's not perfusing. And so the only thing that you could perfuse the brain with is CPR. So, and it is controversial, the topic, and maybe if the map is 5, that's really not a useful perfusion, and maybe you do need to do CPR also. But I think this is, as a general guideline, is if you can avoid CPR, if you can try to fix the problem, give them a lot of epinephrine, do whatever you have to do to get the pressure up, then that may be a better thing for a very sick patient. And that's basically it. So to recap, Sim is really great. Ben Kaufman and Tom Brady are probably the same person. LVAD patients are very sick. They have a whole host of problems. ABCDs, IVO2 monitor, get the LVAD coordinator on board. Check the LVAD machine itself. Get a real blood pressure. Try to get an arterial line if you can. EKG, bedside echo, and then know your toolkit. Know what you can fix and what you can't fix. And then I'll definitely answer questions.
What map will the LVAD generate without, like when you're at arrhythmia or something?
Say that again?
What map will the LVAD
So
generate
if the
without
LVAD is working,
contractions?
yeah, if the LVAD is working, oh gosh, I don't know. It depends. It depends on the parameters set by the machine. And you can actually manipulate, I mean, I wouldn't recommend this, but you can increase the flow, increase the work to generate more map. So it depends on whatever parameters are set.
But you need some
Justin Berkowitz? What's that?
You need some great heart function.
You do. If they have like a massive PE and they're not moving blood at all through their pulmonary circulation, then yeah.
I think we also need to be very careful about just getting in an A-line. This patient is probably not going to have a very decent pulse to get this A-line so quickly, and probably should not be spending an enormous amount of time doing that. I mean, there's other life-saving activities that you did talk about, but I mean, you're anticoagulated, you know that. You're messing around with arteries. It's, it could be a very messy complication. And I think we need to think about that very carefully on this type of patient.
Yeah, I thought ephemeral is just way faster than we use it.
Ephemeral
A-line.
arterial line.
I would not mess around the radio. You'd have all that.
I agree. I think, especially because there's no pulsations and you have to do it by anatomy. So I agree. I agree. It's a tough case. But yeah, Dr. G.
I think there's more places that you can get an A-line than in the radial arteries, and it's not a quick, easy, fast thing for the most skilled hands in the room.
Very good point. Dr. G.
I'm curious, so when he was having ventricular dysrhythmias, DTAC and then later VFib, I noticed that Bilateral and then shock was not tried. And I know obviously you have to go through to treat the underlying cause, they're going to keep going back, but was there any contraindication or anything to not trying Bilateral and shocking them again?
I think they did shock, and the shock worked.
So did you get Bilateral?
But I don't think they loaded with amio, and I think it's a.
Yeah, no, that's.
Yeah, I think it is appropriate.
Part of the protocol, you might have tried that.
Yeah.
To give an antiarrhythmic, especially using VTAC once and came out and then went back to VFib and then give an antiarrhythmic and then shock. I know you got shocked.
Yeah.
That was my question. Antiarrhythmic.
I agree. I think amiodarone is appropriate. There's certainly no contraindication to that. Yeah, Dr.
In my older days, I would become a lot more cautious, and I would just go to the board a lot earlier than was in the video. I would call consult, knowing that patient comes in, because none of us really have experience with that. And messing around and trying to get the experience in that scenario, because it's not the right moment. So it's a low level to get cardiology involved. The same as multiple trauma patient. You call trauma right away. You don't mess around with the patient and then go trauma.
Right.
So I think that should be one of the first steps in a case like that.
Okay.
We'll do, and the bigger picture of doing it in SIM, because we can see the cases so infrequent.
Right.
It's a great people.
Okay, thanks guys.